Welcome to our podcast, where we delve into the fascinating world of medicine, research, and healthcare innovation. Today, we have the privilege of introducing Dr. Gilman. Dr. Gilman oversees day to day operations and management of the research hospital on NIH's Bethesda campus, one of the largest such facilities in the world. He also served 35 years in the U.S. Army, culminating as Major General of the U.S. Army Medical Research and Material Command, Fort Detrick, Maryland. He led several Army hospitals during his career. Join us as we explore Dr. Gilman's remarkable journey, his insights into the evolving landscape of medical administration, and his vision for the future of patient-centered care at NIH. Without further ado, let's welcome Dr. Jim Gilman to the podcast.
For people who might be using it, might want to check more out. If you use the given name James, then probably is a better search term. But I grew up in a small town, and in small towns, people with my given name go by Jim 99 times out of 100. So thank you for having me. And I don't necessarily like spending a lot of time talking about myself, but I really welcome the opportunity to talk to people who are thinking about careers in medicine or medical research or medical technology, medical science of any kind, and if I have anything, if my long experience, and it's just about to come to an end, my long experience can be used in any way to help you decide what you want to do with your future, and what people who see this podcast might want to do with their future. Then I'll be here until we run out of things to talk about.
Okay, well, why don't we start with you telling us a little bit about what initially sparked your interest in medicine?
Yeah. So when I went to college, I graduated high school and I went to college. I had no real, I did not have aspirations to go into medicine. I went to an engineering school, and I sort of arrived at the decision to go to an engineering school almost by default. It was a school well known in the area. The place is now called Rose-Hulman Institute of Technology. At the time I made a decision to go to school there, it was called Rose Polytechnic Institute. And it is, at the time I went to school there, it was an all-male school, and it's located just outside of Terre Haute, Indiana. And I was attracted to the school because of the fact that they had a very active placement program, and they pretty much guaranteed that if you could get an engineering degree there in 4 years, that they would be able to help you find a job. They were very, and it wasn't a hollow promise. So that appealed to me. The fact it was a small school. I grew up in a small town. I had in sort of the high school honors kinds of programs. I'd spent a week on a large Big Ten university campus, and I thought it was a little bit overwhelming. So I opted for the smaller school that focused on math and science, and was closer to home, and an environment that I was comfortable in. Yeah. So it was while I was there in my second year that I met somebody who had aspirations of going to medical school. And it started me thinking about medical school rather than an engineering career for the first time. And the more I thought about it, the more I thought that would be good path for me, and I liked the interaction with people that was a little greater sometimes in clinical medicine than in and so before I finished school, I finished my undergraduate education. I completed the requirements to apply to medical school because you couldn't do all the life science things at a small engineering school. And I applied and was accepted to the Indiana University School of Medicine. So
That's really interesting. So you said you wanted to start off as an engineer and then you switched to medicine?
that is correct. I never, at the time, I never understood that that actually the kind of course of study you get in engineering school, I think, is actually really good for preparing someone to go into medicine. That never occurred to me. Again, at the time I started college, medical school was sort of something that I had never even given much thought to. So, but since doing all that, I sort of have come around to the idea that and the engineering school background is actually very good for preparation for medicine. That engineering school is really 4 years, or an undergraduate engineering education is really 4 years of learning how to solve problems. And that's really all doctors do. They solve them, I think, more like engineers do, more like applied scientists do, than they solve them like theoretical scientists or scientific purists do. And when we deal with a patient, we never have all the data we wish we could have. We have to take the data we have and make an empiric estimate of what we think might be the matter, and we implement a solution based on that empiric assessment. And then we see how things turn out. And that's really that tracks actually very well with what engineers are trained to do all along.
So would you say that having that engineer background gave you an advantage over other people who went into the field?
I think it was the right background for me. I don't know that it. I mean, many of my classmates who had the classic pre-medical life sciences background did well, and they did just as well as I did. But it was the right background for me, and it was about application and not about theory. So again, I think most many young people, when they go off to engineering school, are kind of in the same boat I was in. They're not really thinking about medicine. They think that if they know they want to practice medicine or be a physician straight from high school, they're probably more drawn to life science curriculums and pre-med formal pre-med programs. And there are, I think, lots of paths to becoming preparing to become a physician.
That's really interesting that you started off with an engineering background. Well,
Mhm.
then let's move on to a different question. What does it mean to be responsible for patient safety, quality of care, and development of new hospital operation policies?
So the patient safety movement is really a product of how complex medicine has how much technology is involved and how complex medical care has become. And you know, when there weren't very many effective ways to treat serious diseases, heart disease, cancer, what have you, then it was all about you know, compassion, communication, um, uh, somewhat softer skills for physicians. But now we have effective ways to intervene. But when you're intervening in very sick patients, in who have life-threatening diseases, many of those treatments also have risk, and so it's really important that you're trying to make sure that you're maximizing the opportunity for good and minimizing the opportunity for bad. And not that you can ever be 100% certain, especially in the research environment. I mean, if we knew how things turned out, it wouldn't be research anymore. So there's always a bit of unknown, but being prepared for the unknown and trying to make sure that the care that's provided is as safe as possible, and you're not compounding a very difficult to treat disease with medical errors. And that's I would say that's my job. And the NIH Clinical Center is different than any other hospital. You talked about how it's actually the largest in the hospital in the world dedicated to clinical research. So we have lots and lots of very smart scientists. We have lots and lots of experts in difficult to treat and rare diseases. But we don't necessarily have organically. We don't have we don't have the elements that are responsible for ensuring that patients get good, safe care. And so that's the job of the hospital leadership of the NIH Clinical Center, not just mine, but for everybody else on the executive leadership team. And if you were in a health system, then the people who pay for care would have a responsibility to make sure that what patients received was necessary and was good, safe care. Since the NIH Clinical Center is all underwritten by taxpayer dollars, you don't have the checks and balances that the third party payer would provide. So that sort of falls to the executive leadership of the hospital, and it's really important that the people who participate in the clinical research protocols at the NIH Clinical Center have trust that they're getting not only the best science, but also the best care.
Okay, well, that's really cool what you're doing. And given your significant leadership roles, including your tenure in the U.S. Army Medical and Johns Hopkins, could you share some insights into the unique challenges and opportunities in managing large-scale hospitals like the NIH Clinical Center?
Yeah. So, and large hospitals always in the eye of the beholder. 200 beds with probably you know, a census that never gets to 200 is not large in some people's minds. I was involved in the leadership of two of the Army's largest medical centers, and then I ran one of the Army's smallest hospitals as well at Fort Wainwright, Alaska. So it was about 30 beds. So someplace in between there. And in one of the jobs I had in the Army, I actually had oversight over about a dozen healthcare facilities that probably totaled 400 to 500 beds. So I do. So I think that we don't. This is a little different than your question. So, but it's really all about senior level leadership. I think it is about communication. It's about being clear in articulating priorities. It's about um, supporting people and recognizing people who are doing the right things and doing them in the right way. It is about correcting, usually in the right way, in a way that is not humiliating people who are not doing the right things, or they're not doing the right things in the right way. And at the same way, teaching, coaching, educating, mentoring about why the leader thinks that it's not being done in the right way. And so I have a leadership team, people that I see every day, people I talk to every day, and they have to be bought in to the leadership program. They have to be bought into the way I think things need to be done. And then I have a group that I don't see every day, but I see every week probably. And they need to understand what it is I think needs to be done, and why, and the ways I think it needs to be done as well. And they need to they need to see decisions made in a way that's transparent, so they understand why things are being done. Why, especially if what I do appears to be counterintuitive. And then there's a group that I don't see very often that that you need to communicate with indirectly. So what does that mean? Well, it means in town halls. It means in emails that I send out to the organization. I have an email since I arrived at the clinical center. I have an email that I'll call the one main thing, or two main things, or three main things, and it's designed to be extremely succinct. It's designed to be readable in a minute. It's not a long, complicated email with attachments or links. And it's about things that I think are particularly important and particularly timely. I write those myself. I don't have somebody else doing that for me. If I do write things that are longer and require more thought, but I look at those. I look at everything I write and say, well, the people I'm trying to reach understand what I'm trying to say. Being able to see what you do and what you say through the eyes of the people you're trying to lead is really important. And so I think that's really key. People. So I think the basic challenge is communication, and I don't pretend to have solved all of the communication issues. I don't think I've ever been in a large organization where people would say communication is really, really good. I think in the organizations I've led, I think for the most part, what we say is aligned with what we do. and is communicated clearly. And for the most part, if you do that, then most of the people in the organization will be out trying to do the things that you want done and trying to do them in the right way. And then when you see them doing that, you have to acknowledge them and reward them and point out the fact that these people get it. And you do that a lot. And so but communication is far and away the biggest challenge.
Okay, so that's really interesting how you use your leadership role to help communicate with everyone else. You were talking about your time in the military earlier. Would you like to tell us a little bit more about that?
Sure. So everything I have, all I am, all I become has been has been courtesy of the United States Army. It started out with getting all of my undergraduate education and all my medical school education paid for by the Army. The Army is a unique, at least I think, a unique environment from the understand from the perspective of learning about leadership. The Army is never going to hire a CEO from an outside organization. They grow their own, and so as a result, when you're in the military, and it's not just the Army, it's the other services as well. You talk about leadership every day, and periodically throughout a long military career, and mine was 35 years long. The Army would say, okay, you're doing pretty well in the leadership department, so now we're going to send you off to study leadership for longer, even though you've been talking about it every day. And so you learn about sort of leadership at the lower levels, or what the Army would call the tactical level. And then you move up and you study things in more of an operational context, and then you study the strategic environment and strategic leadership, and finally they even send you off to understand how things work in the other services, not just in the Army, or how things work in the interagency environment. So I had a couple of assignments in my career that I interacted with the Indian Health Service and the Department of Health and Human Services and the VA and the Department of Agriculture and the CDC, and so and when you're learning how to be, I was a cardiologist. I still am a cardiologist. So it's when you address problems in medicine, and everybody sitting around the table is a cardiologist. Well, you get one point of view. But if you have gastroenterologists and surgeons and pediatricians and pharmacists and nurses and healthcare administrators all sitting around the table, well, then you get a wider perspective. You get many more different looks at a problem. Probably begin to understand the full scope of the problem, but the solutions then are harder to come by, because you have to take all those perspectives into consideration, and not just look at it from a standard point of view that you learned about as a cardiologist. So and so in a military career, the normal military career will progress through stages where you get a chance to learn about those broader perspectives of problems, and you learn to look at things in not just in terms of, okay, if I do this, that's going to happen, but if I do this, that's going to happen, and then the following are going to happen, what we call the second and third order consequences. And you begin to think about things strategically, and not just in the day-to-day or the current context. And thinking about things strategically often enables you to get at more of the root cause of the problems. And so the solutions are more complex, but if you can generate a solution and you understand the roots of the problem, you're more likely to have a lasting solution than something that really accomplishes something. So, and in a military career, you get exposed to a number of people who have they're amazing leaders. They've excelled in this environment that is basically just one huge leadership laboratory. And they say things, and you listen to those things, and you say, "Oh, that's really cool. I think I'll add that to my leadership vocabulary, or I'll add that to the way I think about solving leadership problems." And you gradually develop sort of an individual leadership philosophy, but your individual leadership philosophy then it has elements that you borrowed from other leadership philosophies, and everything that you read about leadership and everything you studied about leadership, everything you learned at Army schools or DoD schools about leadership. And so it's a unique background for the job I have now in the Department of Health and Human Services at the NIH. But it also, in some ways, that makes it really good, because so many of the other people that I work with come from a traditional medical science, medical research background, and they haven't learned to look at problems in the same way that I learned in that 35 years in the military. And so far, it's worked out pretty well.
That's really interesting how the military has improved your leadership and like how it helps you in your job today.
Yeah. Yeah. So, I mean, if you go back and talk to people who knew me when I was very young, they said, well, he was always a bossy little kid. So, so and it's never, I won't say that I always have enjoyed being in charge, but I never wanted to work for somebody who I didn't think was a good leader. And so some of the reasons why I've done what I've done over the last 20 years, the decision to leave the practice of cardiology and the teaching of cardiology and go out and start running hospitals instead. Some of that's just a product of the fact that I not too many other people are willing to and to do that, and some of the ones who are willing to do it aren't very good at it. So I think people ought to be able to work for someone that they respect. They may not like them, but they need to respect them. And I think for the most part, over the course of the last 20 years, the people who work for me have felt pretty good about their leader.
That's really interesting. So, how do you approach fostering a culture of innovation and continuous improvement within large medical institutions like NIH Clinical Center,
Yeah.
especially when it comes to adopting new technologies or refining existing practices?
So the first thing I do is I remind everybody about what we're here for, which is to do good clinical research, and that means taking really good care of the people that are willing to be subjects in those research efforts. So you have to center everybody, and you have to get them to focus not just on whether this paper is going to appear in the New England Journal of Medicine or another fancy journal, but you have to get them to focus on what it's all about, which is taking good care of the people that are willing to be in our research studies. And in that, then you find common cause. And then if they're willing to focus on the patients and not on themselves, then there has to be and the adoption of a new way of doing things, or the adoption of new technology. Then if it appears at the outset that this is going to make enable us to do a better job for the people we take care of, then it's usually not too hard. If we focus a little too much on if we focus too much on ourselves or one group, the doctors as opposed to the nurses, or the doctors and nurses as opposed to the healthcare administrators or the technologists, then it doesn't work anymore. And so usually it comes back to doing what's right and best for the patients, and at the same time accomplishing our clinical research or clinical science mission. That's, I think, you do. I mean, we are in a heavily regulated space. We have a lot of people who look over the shoulders of hospitals to make sure that they're doing things the right way. And so every once in a while, there has to be kind of, we have to do this because we're going to get in trouble if we don't do it, even if we think it's not especially good or the change is more than we would prefer. But for the most part, it is about trying to get people to focus on the people we take care of.
So, in your opinion, what would you say are some of the most promising technological innovations that have the potential to revolutionize the healthcare delivery?
So I don't know that. So the big thing that's sort of in the news all the time is about artificial intelligence and chat GPT and other things where you can have and I'm not an expert on this, Satwick. I can find you an expert if you want to do a podcast on that, but I'm not an expert. But it basically involves taking huge amounts of data and applying machine learning in an effort to do things that humans usually have to do in a much more manualized way. So I think that is one of the that's what everybody is really talking about now. And I think there is a huge amount of potential benefit there. I would point out that the AI and the large language models rest on the backbone of some digital technologies that like the electronic health record or digital radiology. So in terms of the things that have come along during my career, I think those have probably done more to change medicine. And not everybody would agree change it for the better, but I think for the most part change it for the better. And now we're going to deal with the second and third order effects of all the digitization that has taken place in medicine over the course of the last 50 years. So when I was in college, I actually did a project where we talked about the a computerized medical record. And we went to talk to people in one of the local clinics to see who actually did medical records work. And they thought we were crazy. They thought it just can't possibly happen. But it didn't happen fast, and it's still far from perfect because of issues related to, proprietary interests, and everybody wants to no, there's it takes a lot of consensus building to get everybody to do things the same way, and sometimes you have to be willing to compromise some of your self-interest in order to do that. So, but I do think that now we have the ability to take all that all that work that we did to create electronic health records and be able to mine huge amounts of data and the very fast processing speeds, and develop new algorithms for the analysis at a speed of the computer rather than relying on people to be able to do it. I don't know that I don't know what the human element is going to be like. I do think that there is a place for the human at the bedside, and I just went through having my mother just died, and so the hospice experience and the nursing home and all of the people that were involved and taking care of her in the last few months. I'm not sure how AI and machine learning are gonna change what we do in that way, and I do think that there is still a place, an important place actually, for the human element and compassion and being listened to. You always, when you're relying on algorithms that you kind of worry a little bit about whether in a patient history, a patient who starts out giving a history thinking that they have a certain problem, or they want to see a certain kind of solution. Their goal is to be prescribed a certain medication, whether they will be completely forthright and honest in describing their history and describing their symptoms, or whether they'll learn the things to say in order to get the treatment that they want for whatever reason they want it. That, I think there is the potential here for errors and for bad decision making, in AI and machine learning, and I think some of those are documented. I think some of them can be, but I know that we're in the early days, and it's too soon to know exactly how much this is going to change the way we take care of patients and practice medicine.
Okay, well, finally, as one last question, as someone who has held leadership positions across various healthcare organizations, what advice would you have to offer to students who aspire to become healthcare professionals?
So, first of all, recognize that the field is very broad. I think the foundation is always the same. It's always learning how to be a good physician, a good physician scientist. It is about, but obviously there's room for entrepreneurs. There's room for people who focus more on the science and a little bit less on the human interaction. And then there are places for people who really want to touch other people multiple times during the course of the day. So I think so recognize that where your career might lead you might be different than what you think it will be when you start. I think that you have to really like what you do. You have to really like the people you work with, and you have to like the people that you're going to take care of. And recognize that you're committed to a career that will require lifelong learning and adjustments and changes. That if you think that the way medicine is practiced, and when you go to the doctor today or last week, you think it's always going to be practiced that way, I think you're wrong. So there is going to have to be the willingness to change. There's going to have to be the willingness, the commitment to lifelong learning, and at the same time, there's going to have to be the willingness to tolerate a lot of oversight and a lot of governmental involvement in your life, and you're going to because the amount of money that's involved, because of the fact that I think healthcare and health are becoming recognized more as rights and not privileges. Then I think that there will be a lot of governmental oversight, a lot of government involvement in your life, and recognize that you're going to deal with with a lot of bureaucracy, and I don't think there's any way around it. So I think that would be the advice. That there's lots of room for lots of different kinds of people in healthcare and among healthcare professions. There's room for lots and lots of opinions, and there's room for lots and lots of people who see problems and think differently. That we don't have to come out of the same box. We have to know some of the same science, but we don't have to see things in the same way. Okay.
Okay, well, do you have anything else about anything that you would like to add?
No, I would just say that the decision I made not to be an engineer and to go into medicine was, in retrospect, I think a good decision. I have talked with you about my long time in the United States Army, and I feel like the Army was very, very good to me and my family, and I'm grateful to them. The military medical scholarship options are available, and you don't have to commit to 35 years like I did. You can do what most people do, which is get your school paid for and pay back some time and not incur a huge amount of debt. That I think that's something for students to consider. And if anybody wants to talk about those things and the opportunities that the military might offer, as well as the limitations that a military career might offer, then I'd be happy to talk to anybody who watches the podcast and wants to reach out to me and get in touch. Okay.
That sounds good. Well,
Okay.
as we come to the end of this episode, we're grateful to have had the opportunity to engage with Dr. Gilman and explore the intricacies of medical administration and patient care. Thank you, Dr. Gilman. We hope that you have found this episode both informative and inspiring. Join us next time as we continue to explore the frontiers of medicine, research, and innovation. Until then, stay curious and stay engaged in the pursuit of knowledge and progress. Thank you for listening, and we'll see you next time.